Yeah. Sheesh. Watch us how we move like this. Watch us how we move. Oh, yeah. Watch us how we move like this. Watch us how we move. Oh, yeah. Watch us how we move like this. Watch us how we move. Oh, yeah. Watch us how we move like this. Watch us how we move. Oh, yeah. We gon' move like this, like this, like this. Yeah, we gon' move like this, like this. Oh, yeah. We gon' move like this, like this, like this. Yeah, we gon' move like this, like this. Oh, yeah. Watch us how we move like this. Watch us how we move. Oh, yeah. Watch us how we move like this. Watch us how we move. Oh, yeah. Watch us how we move like this. Watch us how we move. Oh, yeah. Watch us how we move like this. Watch us how we move. Oh, yeah. We gon' move like this, like this, like this. Yeah, we gon' move like this, like this. Oh, yeah. We gon' move like this, like this, like this. Yeah, we gon' move like this, like this. Oh, yeah.
Good evening, good afternoon, and greetings wherever you are, especially greetings to the Nigerian participants and everyone all over the globe. I am so excited that we are back with Thursdays Live. I am Professor Flakemi Odedino, and I have the honor of chairing the Nigeria National Cancer Control Plan Technical Working Group. Now, this today is one of the days that we have all been looking forward to. And why are we looking forward to this? Today is our inaugural dialogue with the Nigerian population, for us to be able to just present to you what we have been doing for almost 3 months, and for you to question us about what we have been doing. Please feel free to ask us the hard questions. It's okay. This is what we are supposed to be doing. So I am pretty excited to be here and welcome everyone on behalf of myself and my co-moderator, Dr. Uche. So what does the program look like today? Just really quickly, Thursdays Live, you can actually tune on the YouTube, and you will find us having a live program at exactly 7 p.m. Nigerian time. And we are going to be bringing different programs to you, so please feel free to log on. Every Thursday, we're here to answer your questions. We are here to share what the technical working group is on. The programs will range from clinical programs to information about prostate cancer prevention, detection, treatment, survivorship, and advocacy, to information that focuses on research and innovation and everything in between. But much more importantly, you are going to have on every first Thursday of the month is when we report back to the Nigerian community about what we are doing, and then you can ask us questions, any questions that we have. We are also going to have at least every 3 months what we are having today, which is essentially a town hall program. It is when we come out and we are able to provide updates, and you can ask us questions on any aspects of the program that we have. So I am really excited to be here. We really have an outstanding team that is going to be here to talk about all the projects that we have. So first of all, I'm going to give an overview of our achievements so far. It's going to be in 5 minutes or less. Apparently, I can't give everything that we are doing in 5 minutes or less, but I'm going to have that overview provided, and then we're going to bring our panelists in one at a time to give their 5 minutes overview to be able to work on this. So here, it is my great pleasure to present the 60-day achievement overall that the technical working group has been doing. So just to give you a little bit of background, in April, essentially, the Federal Ministry of Health, under the leadership of the Honorable Minister of Health, as well as the PAMSEC, actually inaugurated several people all over Nigeria, as well as outside Nigeria, to serve as technical working group members for the Nigeria National Cancer Control Plan. What is the work of the technical working group? Our work is to come together, to coordinate, to be able to look at what needs to be done with respect to cancer control in Nigeria, and to work with several institutions and organizations within and outside Nigeria to be able to implement cancer control, with a goal for us to be actually have no cancer health disparities in Nigeria by the year 2030. Not having cancer health disparities does not mean there still would not be cancer, but it will be manageable, and it will be things that we can prevent, that we can detect early, and we can make sure that we have improved quality of life. So what have we been doing for the last 60 plus days? A lot. We started with the idea that for the first 30 days, we have to build a very strong foundation that really will put the systems, the people, the resources together for us to be able to do the work that we are doing. And we were able to do this. As you can see on the screen, we have over 10 active subcommittees that are working very closely. We have leaders at the 6 geopolitical zones, and these leaders for the 6 geopolitical zones are actually going to reporting back to you, the Nigerian people, next week, Thursday, at exactly the same time. We have significant number of TWG members who are working with us, including global leaders. We have really ascertained a very strong reporting system, and we have really done quite a number of significant work to be able to bring us to where we are. So we have the systems in place, we have the resources in place, we have the people in place. One of the things that you've been hearing for the past week and a half that we have been doing is the Social Determinants of Health initiative that really has seen over 700 Nigerians that have who are affected by cancer who have applied for the program. We have over 200 validated and approved awardees, and I believe that Right now, the work is going on to be able to provide a minimum of 100,000 naira to each applicant that has been approved. So you can see that we're really, really hard at work. In addition to that, we've been able to raise significant amount of money that goes towards the social determinants of health initiative. And at this time, I really want to thank the Honorable Minister of Health, um, as well as the permanent secretary for all their commitment in providing 50 million naira towards the social determinants of health initiative. So a lot going on, and I want to just say thanks to all the people who have been doing all the hard work in this area. But I think it's very important that you are able to come in and hear us one at a time. And the first committee that is going to speak is the committee that is focused on treatment. Without much ado, I think Professor Bello is being represented by Dr. Okoyemi Bolajoko to provide the update in this subcommittee.
Good afternoon from here. I am very excited to share what we're doing in our own subcommittee. I am representing Professor Abubakar Bello, who is the chair of the Treatment Care and Patient Navigation Committee. We have had the opportunity to look at what we have currently in Nigeria. One of the things we have done, number one, let me start with what our focus is. We want to strengthen infrastructure and patient pathways. And one of the things we thought about doing and that we have done is to understand what we have. We do have people, we have resources, we have human resources, we have outstanding clinicians, and we do have infrastructures. On my left now, you would see some of our infrastructure. We do have 17 infrastructures, facilities where cancer patients are currently being treated. Although not all of them are fully functional, we also observe that not all of them are functioning at capacity, but we do have them. And when you move up a little bit, you see our workforce operational gap that we identified. It is sad to know that even there are some facilities that do not have enough manpower. They do not have enough people to man the infrastructure. So those are the gaps we have identified. But one of the interesting things that we also found was the fact that we do also have very good resource inventory. I mean, where we do have that. That is because we do have a compendium or an impact report by the NICRAT that we were able to access and evaluate. We also have some of our outstanding clinicians who are already working in this hospital and in this field. They were able to fill us in and let us know which ones are functional, which ones are not at optimal level, and what can we do. And I can assure you that we do have all that in place. We know what we want to do. We do have our priority, and in the next quarter, in the next 3 months, we're going to be testing our framework in selected centers to see how that works, how we can truly navigate our patient to resources that is closer to them. Like what Dr. Dedino just mentioned, that we do have some of our patients that applied for the social determinant of health funding. We're hoping that some of these resources will be used to, at least for transportation, to where some of these facilities are. And some of these facilities would also be open, it will be accessible. I know that there will be opportunity. We're going to fill this information in on a dashboard where it can be accessible, and wherever you are, you will be able to say, okay, I live in Lagos. Where are the cancer center that I can leverage? Where should I get my treatment? And you'll be able to at least pick one that is very close to you. And so one of the things that we're looking at is we're looking at a 4-level referral framework as of now. This can change because we continue to improve on what we have as we receive as we receive contribution and as more data comes in, because one of the things we're doing in our team is to make sure that whatever we do is evidence-based. So the first thing is the level 1 and 2 that we're looking at is entry and diagnosis. When patients come in, we want to make sure that the time, they will not just be looking for what they don't know, but they would have the information ready to know that, okay, after this, I'm going to this place for my test, and this is next and that. So we want to make sure that patients have all that information and they know what they want to do. And then when they are able to do that and they have their biopsies, they have their diagnosis, they can easily move on to the treatment and palliative care phase, depending on what the needs of the patients are. But one of the things we want to do is to make sure that we reduce the time from at the point of diagnosis to the point when care begin. And we really honestly trust that with the other committees that we have, we're just one subcommittee in the whole TWG, and we're being supported by the other subcommittee and outstanding clinicians and investigators. We know that we'll be able to reduce the time from diagnosis to treatment, and we're also trying to see the opportunities. We're going to also make sure that the platform include where people, palliative care, and we're anticipating a lot of support from the public and from private sector and from other non-governmental sectors and even international partners. So we know that this is possible, and we are happy to be working on this, because this is the least we can do for ourselves and for the future of healthcare in Nigeria. Thank you.
Thank you so much, Dr. Bolajoko. We will be bringing Dr. Bolajoko back for all those hard questions that you may have for her. So the next speaker that we have is going to be Dr. Lashebikan, who is going to be speaking really about the fabulous need for workforce. So Dr. Lashebikan, this is all yours now.
All right. Thank you very much, Professor Dedino. Good evening, good afternoon, good morning, depending on where you're joining us from. So the last 2 months for us after the inauguration has been something of a whirlwind, lots of activities going on, basically because we want to try to pull our weight as a workforce development subcommittee and improve the outcome of cancer care in Nigeria. So for us, we know that workforce is the bedrock, is integral to whatever we can achieve, because we know that it's not all about the machines. Machines can be bought, buildings can be built, guidelines can be available. But if we don't have the right people at the right place at the right time who will work the system and ensure that we get the best out of the system, then we are not really going to be making a lot of progress in that regard. So for us, we are looking at developing people to work the system to ultimately improve cancer care and cancer outcomes in Nigeria. And for us at the Workforce Development Subcommittee, our charter is simple. It's basically to try to develop workforce intelligence that will allow us to strengthen workforce pipeline. So I'll explain what I mean in a minute, because when we talk about improving workforce intelligence, it's basically trying to understand what cancer workforce is available in the country, what skills they have, where they are located, and what the gaps are. And then, because we know that when we start talking about developing training or building capacity development, we want to really do it in such a way that it meets the needs of what is on ground and contextualize it so that we can get the best out of it. And so that it's not just scattered or sporadic without really achieving much. And then when we talk about the pipeline, we want to be able to transform people's interests, because now with the NCCP and with a lot of awareness and advocacy with cancer care, we're beginning to see some level of interest within this space. So we want to be able to change or move people from having been just being interested in whatever it is that we're doing to move them from interest to training, and then from training to deployment. Where they are, again, we need to identify the places where the gaps are most pertinent and bridge those gaps. We know that most of the cancer centers, like Dr. Ladeyebo mentioned, Bolajoko, mentioned earlier on, we know that many of these centers, these specialized centers, are in the urban centers, urban cities. But we know that a lot of people who live in the rural communities also need that service, and they need some kind of care to be able to help them along their cancer journey. So with the pipeline, we're looking at moving people from interest to training to deployment, and then obviously retention. We all know about the JAPA syndrome, and it will be an exercise really in futility if we train and then we don't retain them, but we export them to other countries. And then for the ones that we train, we also want to make sure that we have projects or things in place to move them on to leadership potential. So with that as our charge, our work basically is cut out. We have strategic priorities, which include workforce assessment. And so we have already developed survey tools to be able to track where we are. Like Dr. Bolajoko mentioned, we have some data that has already been collected, but this time we really want to understand the cadres, the specialty, first of all, that we need. We're able to track about 18, 19 specialties, which we want to have an eye on, keep a track of, to make sure that they are going to be helpful in improving our cancer outcomes. So we have the workforce assessment, workforce mapping, know where they are, what they have, what the gaps are. And then also we've also built workforce indicators, which helps us to track them, because if we don't know what the gaps are, we will always continue to guess. And now that we want to know, we also need to have measurable indicators that keeps us on track. And so that's the first priority. We moved on to capacity building. We know that most of our patients present late stage, locally advanced in the metastatic setting. How can we help to support patients who are already receiving care? And more importantly, how can we also encourage us as a nation to stage shift and have people coming in earlier? So we identified 3 basic areas that we think would really make a difference in improving outcomes in the country. And so we want to do capacity development around multidisciplinary teams, because we know cancer care is no longer a solo treatment. You have to have multidisciplinary teams, different cadres, different specialties involved in the care of a patient. So we have the MDTs. We also want to improve awareness, and so we're looking at developing capacity at that level. And of course, because we want to build the next generation, we're also looking at developing the early stage investigators as well. As the number of cancer centers are increasing, we don't want to just remain at the treatment level just for treating sake. We now want to really move on to improving the quality of care that we offer as a nation. So we're looking at different specialization pathways, both for the highly skilled, and also because we're thinking of task sharing as a model to improve the workforce that we have now. We're also thinking about how we can equip the other cadres with the requisite competencies that will really allow them to provide care to patients. And so that is informed specialization pathways and the task sharing as well. Like I said, we are currently exporting more than a lot of our healthcare workers, and so we want to reverse that. Now, as part of the workforce assessment that I mentioned, we're looking at assessing what we have locally and also what resources we have within the diaspora region, and so sort of like use that as a reverse brain drain, so that we can at least get some of their expertise in country, but also the ones that are here, look at how we can support them and prevent them from seeking greener pastures outside. Now, we know that there are basically 4 things, really 4 core pillars that allow people to migrate, which include income, stability, career progression, and as well as ability to work with the requisite machines that they have. So we're looking at all that, which forms our retention support. And of course, like I mentioned, global partnerships. This time, not partnering with people for what they want to do, but then really aligning it with our own goals as a nation. And so we're trying to broker partnerships that will allow us to develop as a block based on what we have identified as our major gaps now, and so that we can, move forward. So in terms of achievement, like I said, we have developed our workforce mapping tools, and it's ready to be shared. We have also prioritized a number of activities that we want to do. And recently we working with a public-private partner, the Uncle Clinics and Project Strong, to host like a demonstration pilot of an innovative way of improving workforce around radiotherapy as well. And so these are the achievements that we have had and our ongoing activities. The ESI, we are currently finalizing plans to launch an early stage investigator workshop to build capacity for the early stage career investigators around and transition them really, like I said earlier on, from what they are doing, building, translating from interest to really giving them the competencies and hopefully train them to become the leaders of tomorrow as well. And then we are also working with other subcommittees and within other units to host the National Oncology Spotlight, Research Spotlight, where we will spotlight people that are doing great work in the area of research, aiming again to build a community of practice for researchers, because we know that we need to find solutions for ourselves as well. And then, of course, we are working with the National Clinical Trials Network to build capacity to support the country's plan through the NCCP to expand clinical trials in Nigeria. So in a nutshell, that is what we've been doing. And we know that by the time we've executed many of these things, we would have been able to contribute to improving cancer outcomes in Nigeria. So with that, I'll hand it over to Professor Odedino.
Okay, wow, wow, wow. So as you can hear, from Dr. Bolajoko and now from Dr. Lashibikon, it seems as if this has kind of been going on for 2 years. This is just under 3 months that we've started. But there's one thing that Dr. Lashibikon did not share. So I'm going to hold that down to share it because Dr. Lashibikon is a commissioner. So you need to talk to us about that part because it has significant importance and impact for the work that you're doing in leading the workforce. So can you tell us a little bit about that?
Yes, definitely. So Lancet Oncology Commissioner around workforce crisis globally. And with that commission report, we identified that within the next, by 2050, there'll be 100 million people deficit in terms of the workforce globally. And as you can imagine, most of that will be in the LMIC. Nigeria is 1/5 of Africa. So again, if you do the math, you see that a lot of it will be happening here. So what that commission did was to look at where we are, like do the workforce analysis, where we are in terms of what is available. And then one interesting thing I think I'd really like to highlight is the modeling that was done within the commission report, micro simulation that was done to look at what is available, try to model it for what will happen by 2050, and also model it to see which intervention around specialty will give us the best buy. And so for many countries, it was actually around diagnosis, but we haven't done that in Nigeria. And we're hoping that we'll be able to do that to understand what our own needs are. So we're looking at that where most people said maybe with the best return on investment will happen around diagnosis and specifically around cancer surgery. But for us, it kind of like will make sense, but then I think for us, it will not just be one specialty or one part of the cancer continuum, because if we have a lot of efforts around diagnosis, what now happens upstream if we don't take care of the people that are going to treat and make sure that the competencies and the skill sets that are required to ensure good quality treatment happens. So I think that by the time we have all of this data that is there, we will now be able to do our own micro simulation, our own modeling, and we will now be able to identify which touch points and which areas will give us the best return on investment in terms of what we need to do to scale and improve workforce.
Yeah, this is one thing that I love about this TWG membership and leaders, because these are the leaders that are on here. They literally are so passionate. They could talk on and on and on. Thank you so much, Dr. Lashabiko. We're going to bring you back for the question and answer. And now we are going to have Professor Catherine Oladoyinbo, who is going to be talking about the work that is going on community outreach and engagement. Over to you, Professor Lado.
Thank you very much, Prof. Okay, so the Community Outreach and Engagement Subcommittee, we've our one of the things that we have been assigned to do is to see how we are going to reach out to the community. And when we talk about the community, we're talking about everybody in the community, starting from you and myself and all the people who have been affected with cancer. So how are we going to reach out to them? What do we need to reach out to them? What information are we bringing into the community? So that is what the Community Outreach and Engagement Subcommittee, it's all about. What strategy are we using? Which approach are we using? What information are we providing for them? And the subcommittee, over the few months that the NCCP subcommittee has been created, we've been able to come up with some of achievements in this subcommittee. One of the things that we have been able to do is to develop, we've been able to come up with engagement strategies that we're going to use in some of our report that we submitted. One of the things that one of the key things that was really notable in that report was the strategy that we're going to adopt in reaching the community. And in the logic model that was developed by the subcommittee, we talked about the guide that we're going to use for planning and for implementation, for monitoring of all these community outreach and engagement activities in the communities. Some of the things that we decided to do, and which we have done actually in the subcommittee, is that we have identified, both in rural and in the urban communities, Nigeria being a very diverse community, we have identified what is going to work in the rural communities and what is going to work in the urban community approach that we're going to use in the different settings. And we're going to be leveraging on the faith-based organizations, the traditional rulers, existing community structures, the CDAs, market men and women, market unions, associations, NURTW, and all of that. And most especially, we're also going to be working with the cancer survivors champions themselves, because they can tell the stories better to the community, to members of the community. So that is one of the things that we have been able to do. And another thing that we have been able to achieve in the subcommittee is that we have constituted some members of the committee have been put in specific groups, and their major function in those groups is to develop IEC materials, that's educational and training materials that will be used to create awareness, education on cancer prevention, screening, uptake, behavioral, lifestyle modifications, things that we need to do in our different communities. And the members of this subcommittees, because they are members of the community outreach and engagement subcommittee, but we have put ourselves in different cancer types, and each of these subcommittees in this subcommittee are to develop educational materials that are going to be used in the different communities, in the rural areas and in the urban areas. We're also going to be leveraging on the social media to put up
information, on awareness, on cancer prevention, in our different social media handles. And one of the things that we also said in this subcommittee is that most of the information, the IEC material that are going to be put on the social media especially, has to be well reviewed by the subcommittee. We want to avoid situations where members of the community are misled, where they get the wrong information. So we want to ensure that all information that is going to be put out from the NCCP website, all information that we put out from different groups under the NCCP subcommittees are going to be reviewed and authenticated by the subcommittee, so that there will be a consistency. And all this, we're going to be looking at the different cancer types, especially the major cancer types, and those information will be put out. We have also agreed and come to a conclusion that some of these, by the end of August, that all our IEC materials should have been ready for the different types of cancers, and then we will begin to put them out on our social handle medias, so you can follow the NCCP on Twitter, on LinkedIn, on Facebook, on YouTube, and then you begin to see information that can be used for our different outreaches, pamphlets, videos that we can use for our different outreaches, wherever we want to use them, whether it's in the rural area or in the urban area. So those are some of the few things that we have been able to do in the Community Outreach and Engagement Subcommittee. Thank you very much.
Thank you so much, Professor Oladoyinbo. That is so great. A lot going on. I just want you to just mention briefly before we go to the Q&A. I think it's very important, because your committee is the COE committee, to mention the representativeness of cancer advocates and survivors in the work that we do. If you could just briefly describe that, which will be part of your presentation.
Okay, thank you very much. One of the major problems in Nigeria, especially, is late presentation of cancer for treatment. When people come to the hospital, is always late, and that story has been on and on and on for a very long time. We want to change that narrative, and so our cancer survivors champions, they can tell the story better than anyone, because they have passed through the journey. And so in the development of our IEC materials in our subcommittee, we have cancer survivors joining us to help us tailor the information in such a way that those who are affected by the disease, or those who have not been affected, will be able to understand the information better. So they are helping us with the correct language to use in passing across some of those messages to the community.
Thank you, Professor Oladoyinbo. So first of all, I'm so impressed that the Abeokuta weather did not mess with your Wi-Fi. So that is great. Thank you so much. We will bring you back, Professor Oladoyinbo, during the question and answer. Next, we have Mr. Doyin Badamosi, and it's an area that you all definitely want to listen to, which is going to focus on AI, and technology. Strange to me, but it is great for him.
Yeah, thank you very much, Prof. Appreciate this. Can we go to next? Yeah, can we go to next? Yeah, thank you very much. This past barely over 60 days, hitting the ground running meant for us doing a fair assessment of what does the future look like. And defining the future is to understand exactly what sort of outcomes we want. And in defining that outcomes is to understand what do we need to get there. And if we know what we need to get there, what do we have and what don't we have? So that's why we start with this slide. This is the first thing we had to pull in place to be able to, and this is an OKR infographic that just tells us over the next 12 months, this is what we hope to achieve. And that's what we have mapped out here. We've identified 6 core activities or work streams, as the case might be, that are crucial towards building an infrastructure that makes it possible for us as a country to be able to leverage technology, especially artificial intelligence, to improve patient care across different cancer continuum. Whether it's from an early diagnosis point of view or from a treatment point of view or staging, or whatever the case might be. So we start first by understanding what sort of cancer data. So the first work stream for us has been identifying 6 work streams. One being the cancer data and integrity. Second being the digital infrastructure. What sort of digital infrastructure do we have available in the country as it is today? How is cancer data aggregated or collated? Do we have independent sources for cancer data, or is it just dependent on Globacon? And how is this data populated, whether it's from a hospital-based registry or population-based registry? How are they synchronized, if they are? Thirdly is then understand what sort of data and what sort of structure or form of data do we need to be able to leverage technology like artificial intelligence to improve cancer care, innovation and research. And then the other is also capacity development. And in that, we're talking in terms of, in fact, skipping beyond that as well into governance, merging that together. How are these data populated? Are the data populated in a standardized form, or is it different from hospital to hospital? Because that becomes very useful when we're beginning to aggregate data in order to leverage technology on. And also making sense of the logic of financing and identifying strategic partners from an infrastructure point of view, because it's one thing to identify what sort of infrastructure we need, is another thing to understand what sort of method or strategy can we use to finance this significant infrastructure costs in some cases. Can you go to the next slide? And what we're doing with in the next slide now is looking at the work stream 1, and that's where our top priority is now. And within the work stream 1, which is around the cancer data integrity, that's where the focus has been. We pulled out an RFA a couple of weeks ago. We have shortlisted about 22 early stage investigators who would work with us on this really elaborate project. And this is about just looking for me, making sense of what sort of data do we have today. Just making sense of that. What sort of what's at this data? What's the nature and structure of the data? Where are they? Are they fragmented or are they aggregated? And so that's the work in which we have enrolled. We're enrolling. We're onboarding them in the next in this coming week. We're onboarding the ESIs will be working with us to be able to, and we'll be working with the geopolitical subcommittees as well. In order to help us as we interact with different hospital systems, different registries in different geopolitical zones in making sense of this data infrastructure. So that's what our objective is right now, is really beginning to work through what's the integrity of the data that we have currently. So if we look at this, doing an assessment of what we have today, and then defining what ought to be, and then implementing a plan to get us from whatever the gap is that exists between where we are today from a data integrity point of view to where we ought to be. So that's where our goal, that's what our goals are, and that's what we're working on. I'll be happy to take up a lot of questions without sounding too technical when the time is right. Thank you, bro.
Thank you so much. I see all the hard work that is going on, and this is really a novel and innovative, area for us. So how has it been? Just getting and doing a deep dive into the area of AI and technology in Nigeria.
Yeah, I think what's interesting around AI feeds off data. So which means for us, it's something interesting which I think Dr. Lashabikon mentioned earlier on in terms of trying to identify where this area of significant impact exists. And and that's real. And if we say that we get the most return from diagnosis, the reality is we need data to make sense. Even from a policy point of view, when is something an epidemic? We don't know that because a lot of the data we have is lagging data. And do we have the cancer? Is the incidence of cancer, is it uniform across the country? Maybe not. Maybe it's more predominant in certain areas than in other areas. But at what point do we get to know that? And
Yeah.
so intervention is lagging because data is lagging. And so,
Mm.
which means that the burden of cancer keeps increasing.
Yeah. Well, we have you and your subcommittee to help us work with that. So thank you so much. We will bring you back for the questions. And next, we are going to actually bring on one of the hardest working subcommittees. They didn't have any choice. The partnership, mobilization, and financing. We're going to have Mr. Chris Chukwenyere give us an update on what they've been doing. Thank you.
Thank you very much, Prof. Good evening from Nigeria. And I want to bring you greetings from the chair of the subcommittee, the First Lady of Imo State, and also the co-chair, Francis Fumi Oduni. And we'll just be giving a report on what we're doing at the Partnership, Resource Mobilization and Financing Subcommittee. First, we have a mandate, and the mandate is to help build relationships, resources and strategic collaborations that are required to actually support the implementation of the National Cancer Control Plan. It's important to also note that we're not just about fundraising. It's important that we connect people, institutions, expertise, and relevant stakeholders that can actually help to accelerate the National Cancer Control Plan implementation and its sustainability in the country. And so we've been able to do quite a number of things. First, it was important to just have a very strong foundation because we understood that the work is very important. It's going to be transformational. And it was important to really build a very strong foundation when it comes to operationalizing the subcommittee and ensuring that everyone actually aligns with the terms of reference, and also to just ensure that we're able to convene very important critical meetings and to ensure that effective decision makings are done. And we tried to see how we could also develop work streams because we found out that there's a lot of work that is being placed on our shoulders, and it's important to be able to develop work streams that can help us, effectively achieve our goals. So there's the resource mobilization work stream even within the subcommittee. There's the media and communication. There's strategic partnership identification work stream. So we had like 5 work streams that can actually help direct, the priorities that we have as a subcommittee. And of course, we didn't just look at that foundation and an area of just strategic partnerships and building a very solid front. We also looked at the area of resource mobilization and financing. And some of the areas that we looked at was, of course, when we came in, we just landed on our shoulders, and it was a natural responsibility for us to support the social determinants of health initiative. And so that was what we started running with, supporting the entire process. And so we also contributed to financing, governance, and sustainability conversations that we will keep having because we know that this initiative, requires a lot of funding and it cuts across every of the subcommittees that we are supporting. And so we also looked at mapping several or certain partnerships, just identifying priority partnerships and resource mobilization work streams. Right now, we're actually still building on that process to be able to see who are the partners that we would map, and what are the channels that we can actually use for resource mobilization, and putting all of that together to also help us, because, we know that that is very critical to the entire process. And also we started, developing structured partnership pipelines as well. So we're developing a list, of partners, and then we're working to see how we can effectively coordinate with them. Now, within the other area that we've also, worked on is the coordination and system strengthening aspect. So we introduced stakeholder engagement coordination process because really this work that we're doing when it comes to our subcommittee is really stakeholder management heavy as well as stakeholder engagement. So it was important to begin to introduce the engagement coordination process within the subcommittee. We supported, the letterhead development that we can actually use also to engage with partners. We initiated the NCCP partner directory discussions as well. So we are populating that directory. That will also help us, as we begin to engage partners in the nearest future. And then we also mobilize members updates, reporting and collaboration activities. And of course, we're glad for the initiative and the way that it is structured. We have ESIs, we have people who are assisting the subcommittee to ensure that most of our reportings are effectively done and coordinated. And the other aspect that we're really very much working on is the area of community and diaspora engagement. We know that there's a lot of resources outside of the country that can actually support in the area of expertise, in the area of networks, connections, even fundraising, research, to be able to help accelerate the work that we're doing, the NCCP technical working group. And so it was important to begin to engage, communities, engage the diaspora groups as well. And during this short period, we've been able to engage more than 200 community members through outreach and networking activities. It was just an opportunity to begin to connect with leaders, connect with young people, youth, and diaspora stakeholders to begin to have the conversation that builds awareness, that encourages more conversations around partnership, around bringing their expertise, their connect, and everything that they have to the table, so that can actually help to successfully implement what we're doing. And so we also have expanded visibility through community and diaspora engagement. And this is also very important. We're looking at just identifying future opportunities for awareness, partnership, stakeholder mobilization, and all. And we have very critical priority areas, which are first the private sector engagement. We're looking at that area because we know that there could be some partnerships, some resources that can be mobilized from that end. We're looking at diaspora and international partnerships as well. We're looking at also even just assessing grants and proposal development, because we know that that is also one channel that funding can also come in. And the truth is we're actually doing a lot. In the short period that we've worked so far, we've done a lot that we can actually use to assess grants. We are still building on that profile, but then we see a huge opportunity there. And we know that when it comes to partnership, when it comes to stakeholder engagement, when it comes to resource mobilization, there's need for visibility. There's need for potential partners, potential donors to see the work that we are doing. You can't be doing great work and you're hiding. So we are working, going to be working closely with the media and communication team to ensure that there's a lot of visibility on the work that we're doing that can also engender partnership and engender resource mobilization. And then the other part that we're also looking at is partnership mapping and database development, which we're already doing. And one of the things that we've also done is to intentionally support the NCCP subcommittees, just to ensure that these other subcommittees are supported by by us, and we are also in the knowledge of what is going on within these subcommittees, because it also gives us an idea of areas how we can focus, in helping them, also supporting them to help build partnership or areas of opportunities that we can identify within the subcommittees that we can actually use to fundraise or, mobilize resources. And so, workforce development, community outreach and engagement, M&E, and every other subcommittee, even the regional also committees, we're also working closely with them to ensure that we provide the type of support that they need, and also just ensure that we identify opportunities within the subcommittee. So in the next 90 days, we have some work ahead of us. We're going to be expanding strategic partnerships because we believe that partnerships are leverages. Partnerships are tools that we can actually use to be able to effectively achieve the goals that we have set to achieve as a subcommittee. And then to complete the NCCP Partner Directory, we have already started the process. We will work to complete that within the next 90 days. We're going to strengthen funding and resource mobilization opportunities as we keep mapping stakeholders, mapping organizations, and categorizing them, whether as CSRs that they can bring in, or as grant funding that they can bring in, or just partnerships that create opportunities for resource mobilization or financing, or even just engaging the government to ensure that they allocate more funding to some of the funding that they're making available for cancer patients, for instance, the Cancer Health Funds. So we're looking at strengthening some of this funding and resource mobilization opportunities. And we're also going to increase diaspora and international engagement. We see a huge opportunity with the diaspora community, and so we're going to continue to push in that aspect. And then we're going to support the social determinants of health implementation and sustainability. That has been one of our quickest wins within the past 90 days. And we would ensure that there's sustainability in that regard, because it's one thing to start the process, it's another thing to sustain it, and sustaining it requires consistent funding in that pipeline. And so we're going to work to see how that will be sustained, and also to build a stronger partnership ecosystem for cancer control. We don't want to be, we don't have organizations or institutions operate in silos. That fragmentation, we want to bridge that gap and to ensure that there's stronger partnership amongst us in the ecosystem to be able to push towards successfully implementing the NCCP. And so our goal is to just see that, we have stronger partnership and sustainable financing, because it's really essential to achieving a cancer-free Nigeria. We believe that together we are building relationships, resources, and systems needed to turn the NCCP into measurable impact for patients, families, and communities. Thank you very much. I would stop here and wait for questions when it's time.
Thank you so much, Mr. Chris Chukwueze. I think your subcommittee, like I said, is one of the most hardworking subcommittees that you have. But in addition, it's one of those subcommittees that people literally are coming into and asking, how can I join? How can I be part of this? How can I partner? In general, do you have a general statement before I bring others in for us for the Q&A section that we have?
Yes, so partnership is key, and we're very open to partnership. We want as many institutions, as many individuals to come partner with us. Currently, we're actually looking at a workflow, and it's on the approval process to review, it's a partnership review and approval workflow that we're actually working on. And that is just to be able to help us effectively coordinate and review partners who are coming in. So please feel free to reach out to the NCCP, feel free to reach out to us. We're open to partnerships, and we want to be able to have shared goals, shared vision when it comes to improving cancer outcomes in the country. So we are open to partnerships. Once the platform, is ready, we will also share it on the different social media platforms to also encourage everyone to work with us. We are very open to partnerships. Thank you.
Yeah. Great. Okay, so everybody put on your camera, Dr. Bolajuko, Mr. but mostly is Q&A time. So one of the things, like, this is just fabulous. I mean, hearing what has been done for the past just a little bit over 60 days is almost impossible to fathom. So we know that it's not just been done in the past 60 days. It's borrowing from all your expertise and the work that you've been doing in other areas globally, and tapping on all these resources to bring it together. But before we go into our Q&A questions, I have a question for you. So this is a curveball question that is just coming at you. I want to hear the before of when you learned that you are going to be part of the technical working group. What were your expectations? And now the after you spend 60 plus days, how does it feel? Let me start with you, Dr. Lashibiko. How does it feel? Were there any surprises? Was it like what you expected?
Yes, there was a lot of surprises, definitely lots of surprises. I have been in different TWGs over the years, and the expectation was we get into a TWG. I did not envisage I was getting on a roller coaster ride, but it's been a lot of work. It's been very engaging. It's been very interesting. And for the first time, I see light at the end of the tunnel. I see hope. I mean, everybody has been amazing, bringing their A game, just listening to all the other subcommittee representatives. I mean, and we have 10 different subcommittees working on the NCP. So, I mean, it just tells you the amount of work that is happening. And honestly, I really do see that cancer care in Nigeria is definitely taking a different pathway. The narrative for sure is going to change. And I think that for me, that's just what makes me keep wanting to go on and keep putting in the work. And thank you for making the workforce. This is the first time human resource for health or workforce development is as a standalone pillar in our national cancer control plan. I mean, it couldn't have really come at a better time. Yeah.
Yeah, that's due to your all your hard work. We know you've been pushing behind the scenes to make sure that, especially with these issues of JAPA has really taken off. And then how do we tap into this? This is you are really a foundational corner of what we do. So let me go to Professor Lado Ibo. I'm not sure whether you've ever been in a TWG at the national level before, but tell us how you feel. Just your being part of the TWG.
Yeah, initially when I got the notification, I was like, this is a big task, and I really did not know the volume of work that we're going to do until we started. It was when we started I got to know what I've gotten myself into. So it's been very interesting. It's been a lot of work, meetings, trying to, especially when you're working with Reggie Simons is somebody that just puts you on your toes. Yeah. So, and we're in the same group working on development of IEC for prostate cancer. So, you just have to just be on your feet, getting ready to work. So it's been a lot of work, but it's been very interesting. And also working with some of our advocates, bringing them into the group, getting their contributions for the different types of cancers. It's changing my perspective a lot about the cancer treatment, cancer prevention in Nigeria. And I believe strongly that the rate at which the NCCP subcommittees at the rate at which we are going, I see by the end of the year that we'll have achieved a lot of progress in achieving some of our set objectives at the beginning of setting up this subcommittee. So thank you very much for including me.
Okay, Mr. Baramosi, your thoughts? And you are bringing a little bit different perspective because you don't live in Nigeria. So you are one of the people in the diaspora that were engaged to be part of this.
Yeah, thank you very much, Prof. I initially thought okay, how hard can this get? It's I mean, it's pro bono public work, so it's going to be a few meetings, do a few outlines, and but I think it is true that the company you keep influences your perspective. It was interesting to see that the people of course, led by yourself, Professor Dedino, the people on board were not taking this as another public service engagement. It's almost like, hey, we have a chance to make a huge difference. This is it. It's game night, and that's a whole different shift because it means that this is just as much work as it is my day job. it means mapping out this whole thing and not thinking about it as, oh, will government support this, or will the systems be able to absorb this? It's saying, no, disregard all that. Let's say, what will it take to get it done? And taking that approach means that for me, it feels like doing the Lord's work. It's a lot of work. I don't know how else to say that, but it's a lot of work, but it's going to be a lot much more work. But I think the benefit is really realizing that we're not dealing with numbers, we're dealing with people, we're dealing with hopes, we're dealing with dreams, we're dealing with families that are impacted in ways beyond uh, in ways that are beyond what you and I might be able to um, to comprehend. So that, I think, is a huge motivating factor. I mean, case in point is the stuff you sent, realizing that one of the beneficiaries of the social determinants of health didn't leave to benefit from that. I mean, that just brings it home, to know that the work we do is important, and so it's a privilege, and that just makes it pay off.
Yeah, I think that's sort of what I'm also finding out. But Mr. Chris Chukwuere, I know that you've done the City Challenge, you've sort of been in some of those things. How has your experience been with the TWG?
It's been amazing and also surprising, because you know how you go to a new environment and you have culture shock. There was culture shock being a part of this technical working group because I've been in others and I could see the difference. Representing City Council Challenge, I was also part of the group that developed supported in the development of the plan. So it was, yes, we had knowledge, technical capacity to bring in, develop the plan. And even during the launch, Prof, you were around. We're on a panel with Dr. Baka. We're talking about implementation strategies and all of that. But the talk is different from the action, because with all of the talk and the conversation, you get into the work and you're like, oh my God, And for me, it's the quality of leaders that you've brought to the table. The chairs, the co-chairs, they are machines just like you. And so there is work every day. There is something that we have to do every single minute. Voice notes are coming in, messages are coming in. We have to get this done. And for me, it's the technical capacity of both the individuals and the organizations that are backing them. So the organizations you represent. So Dedino, Mayo Clinic is solidly behind you. Dr. Amaka, UNTH is solidly behind you. Chris, City Council Challenge is solidly behind you. So it's that technical capacity that is bringing a lot of quality to what we're doing. And the truth is, we don't actually, for me, I didn't know that there was this type of capacity in the country when it comes to coming together in a technical working group. The expressions are amazing, and so it's that drive for excellence. And for me, it also makes me see reasons why we say that cancer is an emergency. Because if you're not quick in the process of transforming and improving outcomes, patients will be dying while you're doing what you're doing. So I've seen this several times, and I'm really glad with the sense of urgency that the technical working group is actually using to drive this process. So I'm really grateful and very thankful that I'm here. And I've also been very much supported by City Cancer Challenge to just keep supporting this. In fact, City Cancer Challenge is proud that we're a part of this, so I'm really, really grateful for that. Thank you.
Yeah, thank you. I think, the two mentions of that sense of urgency, I think is so important, and that needs to be here. So I really hope that, the cancer patients, the survivors, the families, the communities that are affected by cancer, they really know that we are working with a sense of urgency. We're not chilling, we're not relaxing. And it's almost 24/7 because you have people all over the world. So as you are falling asleep and sleeping, people are up in the other ways. And then you wake up, it's like, oh my goodness, there's like multiple voice notes and emails and whatever. But it's hard work, like I always say. So Dr. Bolajoko, yours is a little bit different because yours, you decided and completed the form and say, I want to be part of the program delivery unit. So can you talk a little bit, and you literally are the leader of the program delivery unit. So can you talk a little bit about what your expectations were and how it's been for you as an early stage investigator in being part of this work?
Thank you, Dr. Dedino. I think, like you said, my expectation is probably different from others. That is because I've heard a lot from you already before the program started. So I knew that I had an idea that it's going to be, it's going to be tough trying to build something like this. Like Mr. Chris said, it's not just the talk is easy, but the implementation itself. So for me, I'm just like an open book. I opened my mind and I applied. And then, you recall I told you I didn't get what I want. I didn't get the subcommittee I really wanted. And Dr. Dedina was like, no, you're going to have to be where you are now. And I'm very excited that I'm actually in this subcommittee, and then the opportunity to also coordinate the early stage investigator is a privilege for me, but I know it's a lot of work. But it's almost like I saw some of those things coming, because I know when you are working with Dr. Dedino, it's going to be a long haul. And I've had the privilege of working with you for some time, and I know. But one of the things I had to change is my habit, the way I use WhatsApp, because I don't check my WhatsApp often. But now I have to, when I wake up in the morning, I have to at least go through the WhatsApp before I do anything, so that I can know what I need to prepare for the day. And it's just a huge privilege to see what we can do, and working with outstanding clinicians, investigators, now working, I see them very afar off, like Dr. Lashe Bikon, Professor Bello. I see their name, I read articles, but now to see them in the same team working, it's really a privilege for me, and I'm very grateful for it.
Okay, great. Yes, it's really a hard work, and I think I'm very warm to how responsive people have always been. Yes, Mr. Chris Chukwuyere, I definitely remember the NCCP launch, and I definitely remember being on the panel that was moderated by Dr. Leshibiko. And I do remember saying to Dr. Uche, please get it right this time. The implementation is the goal. And I came back to the US, and like, lo and behold, he conspired against me and said, well, you want implementation? Go ahead and chair the technical working group. But it's been a great pleasure, and I'm working with him too, working with Dr. Uche and the DG for NACRAC. I think it's been a great pleasure. So we are going to start rapid questions. So please keep your answers to not more than 1 minute. I hate to mute your mute your mic. So please keep it to 1 minute. And the way we're going to have it is that I'm going to ask each person a question and then go to go to 2 or 3 questions from the audience and then ask a series of questions that have been submitted so far already. So starting with the treatment care coordination and patient navigation, Dr. Balajoko, and we keep mixing Dr. Oladoyibo and Dr. Balajoko together. It's not that it's not Professor Oladoyibo together. Professor Oladoyibo has been Dr. Bolajoko's mentor for donkey years. So they've started looking alike, started sounding alike. Their names started sounding alike. So that's why we mix them up together. But so it's all good. They don't mind. So Dr. Bolajoko, so this question actually goes to you. Many cancer patients struggle to navigate the healthcare system. What is the subcommittee doing to improve coordination and ensure patients receive timely care? I think that is really a big thing that needs to be addressed.
Yes, yes. In my presentation, one of the things that we're looking at is creating a dynamic dashboard where we can have all the centers that we currently have that are providing services, both radiotherapy and nuclear medicine and surgical therapy, so that we want to create a one-stop shop where you get to, at least the one that is closest to you. And then we're hoping that when we are able to create this dashboard, then we'll be able to have, we plan to pilot with some of our clinicians to see how that works, how number one, they'll be able to, if they will be able to integrate it into their workflow, the workflow, the standard the procedure of caring for patients. So we are hoping that this platform will be dynamic. It will be a dynamic resource where people can go, both professionals, non-professionals, patients, they can go and just know where to get, especially the centers, where they can go, which one is closest to them. But one of those things that we're also looking at is to be able to map we know there are a lot of NGOs that are providing services. So although we have not done that part now, is to be able to map out some of those NGOs that have programs that can meet the needs of this patient. So that is one thing, that's our goal. In the next 3 months, that is what we want to do. We're hoping that this will reduce the wait time before treatment, and even during treatment, it's also really help patients navigate care.
Mm-hmm. Thank you, Dr. Bolajoko. The next question goes to you, Dr. Lashibiko, and this is no surprise to you. Nigeria faces shortages in several oncology disciplines. How is the NCCP addressing workforce capacity challenges?
Yeah, like you said, no surprises there. Lots of deficiencies, lots around the place. So for us, gathering information really for us is the first place to start. And like I said in the presentation, we're actually mapping out what currently exists. We first of all started by identifying the different specialties that are required to improve cancer care. So like I said, we mapped out about between 18 to 19 of those specialties. So it's not just physicians, we have nurses, pharmacists, biomedical engineers, even researchers and managers as well. So we've mapped out all these specialties that we think really have a critical role to play in making sure that someone with a diagnosis of cancer actually has access to good treatment, and not just even diagnosis, survivorship care along the entire cancer continuum. So for us, we think that that is critical to understand where we are. And that's the foundational bit that we're looking at doing now. And then once we're able to do that, we'll now really, again, prioritize those specialties that we think need a bit more. And then we'll also look at those that require, something just to tide them over. And we're looking at really putting a team-based approach in the kind of workforce capacity that we're dealing with. And so MDT training is critical. Putting everybody together. We're also looking at a different model where we're looking at task sharing. And so a bit different from task shifting. So looking at really equipping people with the requisite competencies to do certain things within the MDT structure. So really looking at team-based science. So that is one thing that will come out as a direct from the workforce mapping that we want to do.
Thank you so much, Dr. Lasha Bikon. I'm going to go next to you, Professor Ladoyinbo. I mean, I think a lot of people are still warming up to what community engagement is, especially in Africa. So why do you think community engagement is so essential to having successful cancer control program?
Okay, so there is the community and there is the treatment, the hospitals. So if we don't engage the community, community engagement is basically the process by which we engage the community, providing them with the right information, for them to understand, demystifying what cancer is. So basically, there are a lot of issues around cancer. When people hear the word cancer, most people think is a death sentence, because of low level of awareness, knowledge gaps, needs, and all kinds of things that surround the issue. And so community engagement is that thing that we are doing to ensure that the whole community, everybody in the community understands the need for understands what cancer is, and factors that are associated with the risk of developing cancer, what you need to do, why you need to screen. And so all these, by the time we engage the community, it will help us reduce the number of people who present at the hospital at the advanced stages. Dr. Lakshibikon talked about the problem with our workforce. Right now in the country, we already have a shortage of the workforce of people who address the problem of cancer. Now, having that in, and then we are presenting with so many cases, and especially cases with advanced cancer. So if there's no community engagement, it's going to be like a reoccurring decimal, and it will be getting worse by the day. And so community engagement is that aspect that helps the community to understand what we need to do, why we need to screen. For example, the screening for cervical cancer that is being done, and the giving out the immunizations to young girls. A lot of issues are around it. This is what community engagement does, by enlightening the public, telling them that this is not a way by which we want to reduce the number of girls who can give birth. You hear all kinds of stories, about this immunization. So community engagement basically is providing awareness, to the community. And so it's a duty, it's everybody is involved. Every single person in the community is involved in this community engagement activity. And so we hope that our subgroup and our subcommittee will be able to do a lot to demystify the issue of cancer in Nigeria.
Thank you so much. So well said and so passionately said that the community engagement will greatly help us also in ensuring that we are, downgrading those cancers. So, Mr. Badamosi, I don't know. I know you've been in Nigeria for, not only in Nigeria, but in Africa, globally, and other places, with the issues of AI. So can you talk a little bit, just kind of focusing on Nigeria? Why are data system and digital health so important to achieving cancer-free Nigeria 2030?
Yeah. And I mean, just speaking up from what Professor Ladoyinbo mentioned around misinformation as being one of the reasons why there is late presentation. Maybe that's one. Yeah, that's one of the critical factors. And also, another reality of that is mortality rate. So we have data today that tells us that the incidence of cancer by 2030, 2035 will double what it is today. That's globally. But then the mortality rate in the West is reducing. but the mortality rate in LMICs is growing in tandem with the incidence rate. And that's quite challenging. So the question is, what can we do to stem the tide? So there is outcome. Outcome is driven by patient care. Patient care only occurs when there is diagnosis. And so the question is, how do we facilitate until we have a total cure for cancer? The question now is treatment, right? Early treatment. And what can drive early treatment is early diagnosis. So the only way we can stem the tide is if we can intervene early in the cycle. And we can only intervene early if we can diagnose early. And that's where data systems becomes important. And it becomes significant. It's at two levels. One is at the micro level being at the patient level. How am I able to interpret symptoms in a way where we have systems today where we're able to predict risk of cancer 2 years, up to 2 years before the symptoms becomes clinically evident. That was impossible before now. Now that's data at the micro level. But the reality also is data at the macro level becomes significant. What sort of data are we gathering that's helping us know that prostate cancer is an incident in Northwest Nigeria, for example? And how will policy influence intervention? Policy can only influence intervention if policy is aware that there is an epidemic coming up somewhere else. Data is lagging. And I think that today, and when we're talking cancer-free 2030, we're talking collaborations. Nigeria is blessed with significant amount of talented innovators, talented clinicians. But to intervene in the age we're in today, we need data for that to happen. So by creating the right infrastructure in terms of data infrastructure that makes it possible, almost creating some sort of a sandbox that makes it possible to facilitate research, but also makes it possible to facilitate innovation as well for product development. And I think that's where we're going. That's how we can actually intervene in a multi-pronged approach to address the cancer scourge we're dealing with.
Thank you so much, Mr. Baramosi. I mean, we don't even have any choice right now. We really, really need to be able to do this. One of the things that I'm excited about the use of AI is that all those things that really has been affecting countries like our country, other LMICs, and across the world, is this idea: what can we predict cancer early, right? Can we predict? If we are able to use AI to predict cancer early, that means at the primary care level, even at the primary care level, there could be a person walks in and is like, okay, there's a high chance of you really getting cancer. Let's get you into this system that the treatment and care coordination is talking about, so that you can literally see, an oncologist, or literally see somebody immediately because you are at high risk with this. This is what excites me a lot. I also want to say what excites me about this. What also excites me about this is because being able to do this in a country like Nigeria is actually cancer discoveries for all the other nations. I mean, we are talking about the most populous Black nation in the world. We're talking about a country that majority of our genetic etiology is linked to cancer, and the ability that you have, similarities in cancer science discovery, going on. So more conversations, when we bring in the other subcommittees. But Mr. Chris, over to you. As we have seen in all the reports going on, the NCC has made significant progress in a very short period of time. Can you just give one example how the partnership subcommittee is contributing to the implementation success? Just one example, to just kind of bring in the, people are hearing a lot of us are doing a lot of things, and the TWG a lot of things. I think let's kind of have a key example of how your subcommittee is working to be able to do this.
Yeah, one example is the support that we provided for the Social Determinants of Health initiative. Just looking at how we supported the process through strategic stakeholder engagement and partnership coordination. We actually helped to lay foundation for an initiative that addresses transportation issues, food, nutrition issues, accommodation issues, and other non-medical barriers that patients actually go through that prevents them from accessing cancer care or, to complete their treatment. And I think this is a very strong statement that we've made as a subcommittee and as a nation. Just looking at how the leadership, through Professor Odedino, started with encouraging and inspiring members of the TWG to contribute personally towards the SDOH fund. That, for me, is a strong statement made nationally, because it requires a strong leadership and inspiring leadership to be able to get everyone, despite the work that we are putting in, and people are still contributing personally to it, because this type of committee, people are supposed to be paid for it. But then you see that people are really passionate about adding value to what they've been called to do. So that was a very strong statement. And also the Ministry of Health saw that. They saw that these guys are really very serious, with this. And they could also contribute 50 million naira to, support the initiative and support what we're doing. So that in itself is something that we are very excited about as a subcommittee. And we're already thinking about how we can ensure that there's continuous funding in this pipeline, there's sustainability, because we don't want a case where in the next few months, people are looking forward and hoping and expecting that they will be supported, and then we're saying there's no fund or there's no money. We are thinking about strong strategies, workable strategies that can help, to sustain funding within this pipeline and ensure that more patients, get supported through this. The truth is, this is a very big win for the country. This is a very big win for cancer patients and cancer survivors, because they have seen that the NCCP is prioritizing them. So when it comes to patient-centered care, for instance, in the aspect of treatment, diagnosis, and all, that's one aspect. But this aspect is an aspect where a lot of people don't talk about, and we can lose patients to follow up because of these barriers. And so this is a very big deal for the cancer survivors, and they've seen that we are prioritizing them, we're putting them first, on this initiative, and it is amazing. And for me, I'm very happy to be a part of the subcommittee that is providing this type of support, that provides, access, for patients when it comes to funding. Thank you.
Yeah, that is great. And we want your subcommittee to keep on being excited, because you have, I think we are doing something August 12th. You have a launch, a fundraising launch August 12th. So I hope you are as excited as you.
Some work. We're thinking hard.
I know. So we look forward to you continue to be excited, to continue to raise funds for this great initiative. Now we're going to go on and take some of the hard questions that we have. One of the questions that we have, yes. Dr. Lashe, because you are in the spotlight. Reversing brain drain is a lofty but rather tall order that can only come from addressing the issues you raised, including remunerations and quality of our facilities. I'm actually going to let you handle that first, and then I'm going to call Mr. Bonamosti, because also I think he's also been thinking of this brain drain issue. But this is all yours, Dr. Ashibikon. Go ahead. Take one for
Okay, so that's a very hard question. But I think that it's really also a very important question as well, because it actually made its way into the Lancet Oncology Commission report, where Nigeria was cited as a case study, because globally we know that, yes, that the brain drain from this country is enormous. it's definitely not something we want to trivialize. We really need to look into it. And I think looking into it should happen now more than ever, because one of the things that the federal government did in the last 2 years was to double the intake of medical doctors and nurses as well. So instead of producing like 4,000 thereabout, we're now going to be producing about 8,000 plus doctors. So if we're going to be producing, we can't produce to export. We need to be thinking about keeping them in. And when we look at factors that cost retention, 4 things typically drive people out of the country. One is around cost security, income security, making sure that, when you look at what your peers are earning, that, it kind of makes sense. Right now, it doesn't. So it's understandable if people want to leave. But there are other factors, security, professional career growth, progression, as well as, being able to have the tools to work with. I think that particularly maybe in the area of radiotherapy, the country has seen an increase in the number of treatment centers that are available. So if we look at that, we can say that if it's just for that cadre, that sector, we have them, but it's not enough. We also have to think about how to keep them in. One of the studies that we did looking at brain drain said that one of the push factors was overload, work overload, burnout. And this is where we're really thinking about as a workforce committee. We're looking at really expanding the, looking at innovative ways to bring in more people to support. And so, like I said earlier on, we're looking at different models for task sharing. One of the projects that we have kind of like adopted, the demonstration pilot project, actually, it's kind of like opens up a new chapter where we have people, for instance, therapy radiographers. Now, there's a critical shortage of therapy radiographers in the country as we speak. We know that with the oncologists for the contouring, there's a role for AI. With the medical physicists, there's also a role for that. But with the therapy radiographers, you need the workforce to be there on ground. So there's really no going around it, unless maybe Mr. Badamosu will have ideas to let us know how we can work around it. So that is a specialty that we really need to think about different models to expand what we have now. So the projection really, I think, is a novel way that we are very interested in as a workforce committee, because it kind of like puts in a different set of people, not just the certified radiographers, but a different cadre that can do some under strict supervision, of course, but it also helps to widen the career ladder gap. So with widening career ladder gap, you can project career progression. And like I said earlier, it's one of the things that typically drives people away. So if we now put on our innovation thinking hats to look at which other specialty, which other cadre that we can use and adopt innovative ways to expand it and incorporate them into different aspects, we feel that that's innate human nature of being able to contribute meaningfully to cancer care will be something that will hopefully get them to stay. And I think that, like we've heard all through the conversation today, there's a lot of government buy-in, there's a lot of political will, and I think we can also leverage on that to look at how we can come up with some ways to incentivize the people to stay. And data is king, which is why for us, we are starting at the foundational level of gathering in all the information we need, who we have, where they are, the gaps that exist, including, what it is they are getting, so that we can make that case to say, if we lose them and you have to look at alternative sources, this is what it will cost you. I know that with the Lancet Commission reports, particularly with the cancer surgery, the return on investment was as much as $4. So we should be able to, again, working, of course, with the data people to project that data into meaningful bits that the government will understand, to say that if we're going to incentivize people, this is the return on investment to get them to stay. We can't always produce to export. So I think these are some of the things that we're thinking about, and of course we'll continue to innovate and expand as we grow. But definitely a good question, and definitely something we need to keep an eye on, because we can't continue like this, really.
Yeah, so well said. Dr. Lashley Bicon, and we're so grateful to have you at the helm of this. I mean, there's really no other person I can think of who is such a passionate, dedicated leader in getting this solved. While we are working towards the resolution and working towards this, there are millions of oncology workforce who are Nigerians in the diaspora, or even friends of Nigerians in the diaspora. So, Mr. Blamosa, can you speak maybe a little bit into, how can we begin before we get? These are some of the novelty, So, one example, I've been out of Nigeria for over 30 years. But how do we begin to turn the brain drain into the brain gain and work, with our passionate leader, Dr. Lashley Bicon, in making sure that we're getting things, moving smoothly, because people are still currently being diagnosed. Before we build our workforce, they continue to be diagnosed with cancer. So how do we begin to do that?
And I thank you very much, Prof. And I think there are two ways to look at this. One way is to say the things that technology allows us to be able to automate today, the things that we can address today. And I'll take radiology as an example. Cutting to data, depending on which data you look at, there are between 500 to 700 radiologists in Nigeria. That's effectively 0.23 radiologists for every 100,000. Whereas in OECD countries, the number should be about 10 to 12 radiologists for every 100,000. We don't even have one. And the challenge you have with that is, how do we begin to use technology to bridge some of this gap first? And then how do we begin to leverage human resources that may be available locally? And that's why I like your idea about shared tasks. How do we begin to widen the net of shared tasks, but not just locally, but also globally? And those are the two areas. The first area of using technology allows us to be able to triage earlier on, or maybe if it's preliminary study, so you can have a machine do that, and also triage much earlier on. And so that's one way we're adopting technology. So it has to be a human machine approach. I think the approach we've got to look at is not really reversing brain drain straight away. No, that's going to be quite challenging. I think that what we want to do is to say, what can we use? How can we improve the efficiency of each clinician? How do we make sure that the output is increased significantly by taking out things that we can replace with machine? That's one thing that has to happen. Second thing that needs to occur is then, how do we create a framework, an infrastructure, platform? And I think that's what Prof is talking about, where we can actually leverage the expertise, global expertise of both Nigerians or people of African ancestry or friends of Nigeria who are happy to contribute. How do we harness the technical or scientific expertise or clinical expertise and make that available at the bedside in real time? That's the approach where somebody can still feel, look, I really know I should serve or in my community, but the reality is I live somewhere in Ottawa, for example. I can up my life and go, but if there's a way I can still contribute meaningfully, I would love to do that. That's the kind of infrastructure and system we need to be able to look at. And that's a measure of brain drain in that sense. And I think that's a technology we can implement and begin to look at critically today, to look at shortfall. We have case study of what was done in Rwanda to address this, which we implement. So I think that's where we need to look at.
Yeah, great point. I don't know, Dr. Lashley Bicon, maybe you want to respond to that, but I also want to bring Mr. Chris in, because this is where, this is one of the beauty about the pillars that we have. We call them pillars, although they're subcommittees. The pillars are really working together, because you have only one pillar is not going to work, or you have 10 pillars, then you have a very strong foundation. So I want you, Mr. Chris, get ready to sort of just comment on how you see partnerships now helping, in building that group. But Dr. Lashley Bicon, how would you respond to how we can then leverage AI, right? To be able to do, not everything, AI is not going to do everything, but some of the things that maybe we might be able to do.
Yeah, I mean, great points that Sabadomosi mentioned, and like I said earlier on, we are also looking at engaging the diaspora because we feel that there's a lot that they can give back. One of the surveys that has been created and is ready to launch is actually just that. It's an open call, particularly people in the just all over the place. My co-chair really is also driving that. She's based off in Mayo Clinic, and she also has within her network a lot of people that are really interested in giving back. So that is definitely something we are looking at as well, trying to see where they are, what skills they have, what they can do, and who they can do that for. And I completely agree with him in terms of using technology to be able to help us to bridge that gap. For radiology, we are seeing a lot of remote access to help with diagnosis. That's really a bottleneck for us, especially with telepathology as well. And like I mentioned, even with the oncologists, we have remote access to contouring. So that also helps to reduce the time. And we also have, another AI development that helps us with delineating organs at risk. And so for a patient, it would probably take maybe like 4 hours or 2 hours, depending on the proficiency, really, to do just one patient. And you have, when we look at the numbers, it's terrible. I think for us, we have a ratio of like 1 to 1,800 per oncologist to patients. So having that tool that helps us to delineate organs at risk already takes the burden off and allows the oncologists that are already overworked to be able to really focus on the other things that really needs their own expertise. But for me, I think as much as we want to embrace technology, we should also be guided as well by it. And I know that there are lots of, and Nigeria has some data regulatory laws to help us. And I think as oncologists and as we continue to, progress, is something that we need to know the laws that guide it and what we can do and the limitations that we have. But definitely, we really need to leverage on the technology that exists, because honestly, we cannot bridge that gap in a hurry. We just need to innovate as we go to see what we can do to continue to bridge the gap as much as possible, while trying to get the best. Because it's all about the patients, all about them receiving the care when they need it. Many times diagnosis is delayed and the cancer is not waiting. So we need to be able to help to make sure the diagnosis is done in a timely way, and then the quality of care as well cannot be overemphasized. All of this put in together is what will ultimately make the difference in terms of the outcomes of cancer patients.
Yeah, by the way, I knew that you and Dr. Oladere would be love at first sight. So that's why I put both of you together. Dr. Oladere, your co-chair, I knew both of you will hit it off like like no business. So I'm glad to hear that. Mr. Chris, just really quickly, 1 minute or less, how can your subcommittee now help us with this, with regards to partnership? Because diaspora engagement is one of the things that you mentioned that your subcommittee is focused on.
Yes. So just listening to everyone, one of the things that we've identified in the subcommittee is the fact that reversing brain drain on a practical level, we know it's going to be difficult. Someone who has experienced higher remuneration out there, better infrastructure, facilities, would hardly want to come back. But then it's to now think about how do we innovatively ensure that they're part of what we're doing. And one of the things that we see is very powerful is getting to create awareness and educate people on the importance of why they should give back, and making them see a vision of national transformation, that they can be a part of something meaningful. And we can actually drive, this, of course, with what Dr. Lashabiko has said, we're trying to see a drive where you would have some of these people indicate interest. We can make it a national responsibility, a national drive to say, do we even have a database of cancer care professionals that are out there? Do we have a database? How many are they? But we can start with people indicating interest, driving awareness, driving that education to get people to be a part of it. And, with that, we can be able to have an idea of how we can begin to structure how they can give back to the project that we're doing. Mentorship is important. We have a lot of highly skilled professionals, older professionals who are out there who can actually serve as mentors to younger people who are here. So we need to we're thinking about, okay, so how can we do that? I think we need to all work together to see how we can very much structure that initiative and see how much we can harvest, from the diaspora community. Just one quick example is the technical working group. We have a lot of diaspora members who are giving back to this process, to this initiative. That in itself is encouraging, and we need to have well-structured initiatives like this that would encourage more people to come in. And once they see that we are excellently delivering on what we've said we'll deliver, and it's not the Nigerian technical regular working group that would not do anything, then they would be interested. So excellence is also demanded of us to deliver on this job, so that when we are encouraging others, they would see that these guys are serious and they'll be a part of what we're doing.
Yeah, very well said. I think this workforce is a hot topic. So the next question is, how does your subcommittee on workforce intend to address a potential problem that has resulted in repeated strikes across healthcare in Nigeria, particularly as our health sector is driven by the government? Dr. Lashe, because calling your name.
That's another bullet. Where's Dr. Uche? He needs to help out here.
Dr. Uche did not come, and then he did the question in.
Well, okay. So I think that one of the things that causes the perennial problem of the strike is the environment, the remuneration, basically, not looking into the welfare of the workforce. And like I said, these are some of the things that we're going to be documenting, and we will now present it to the FMOH and then, of course, the labor, because this is really not just just like a treatment or training kind of thing. It's really labor market involved.
Yeah.
So we really need to be able to get the hard facts and get it across to the Ministry of Labor and see what they can do to really help and improve. And to my point, really, which I said earlier on, that we really need to show the business case of ensuring that the healthcare is prioritized, the workforce is prioritized, because this is the engine. If the workforce is not well looked after, well remunerated, I mean, you're going to have a lot of people who are going to be skipping work. The GDP is going to go down because the people who are supposed to drive the economy are not going to be there in the first place. So it's just to show the investment case. And this is why we need all of that foundational data to be able to present it to our lawmakers and leaders and say, if we do not look into the welfare, these people will go, and this is the rebound effect that we're going to be having as a country. But I think I would just also comment on the second part that says that our health sector is driven by government, largely so, but there is a change. We're seeing a lot of private sector involvement in healthcare right now. And there are a lot of policies that are being put out there that health financing solutions that is not now only domiciled within the government sector, but is finding its way into the private sector. And as more and more of that happens, we're going to be seeing a shift. And I think this is where the government sector, the government hospitals need to begin to sit up and look at now, because that shift is happening currently and is going to continue happening, and is going to, with time, reduce the flow into the government sectors, and that again will also reduce the revenue. So that shift is going to happen sooner than we think. Lots of private sector involvement, like lots of public-private sector involvement, and that shift is happening. We need to be conscious of it and know that it's not business as usual anymore, especially when it comes to cancer care. My center, currently we operate, and we've been operating very well for the past 2-3 years. And all this because we have a public-private partnership. And so when the strikes are on, it's insulated. So
Yes.
you have constant care that goes on because of that private sector involvement. And as we begin to see more and more of that shift away from government, it's going to change.
Yeah. You
The
raise a very
NHIA, the other financial solutions that help with patients' care is also shifting. It's also becoming more inclusive, including the private sector into those that can participate at those levels. So there's a shift.
Yeah, very well said, Dr. Lashibikon. This is really an outstanding thought processes that you have put forward. And the beauty of it is that is really increasing. This model, like about 20, 25 years ago, I started seeing this model in the Caribbean. In Bahamas, where they, in a government, healthcare institution, they had a private wing, and it was like private, so functioning. And then the private government collaboration ended up being the private side funding free care for the government side. And it was, so, for me, that was like over 20 years ago when I was in Bahamas with Dr. Robin Roberts. It was so interesting for me to see. And he took me through all the different wings, and he said, that is funding this. This is why this is free, because it's coming from that. It was really very powerful. One of the things that I think, that I think will need to be taken is there actually needs to be an evaluation of these sort of models that we're seeing in Nigeria to really be able to document the impact, right? And see what are the best practices under the condition that it works. Very well said. That is really great. So the next question is actually going to you, Professor Oladoyinbo. How can community organizations and advocates contribute to NCCP if they don't work directly in healthcare system? I guess if they're not working in the healthcare system, what are ways for them to partner with you? We can't hear you, Dr. Oladoyinbo. Professor Oladoyinbo, I think, can you say something?
Yes.
Okay, we can
Sorry,
hear you now.
I was muted. Sorry, I was muted. So, community organizations. So, one of the things that we are doing in our subcommittees, one of the strategies that we are adopting is to document as many existing structures of community organizations, organizations that are already in existence. So, some of those we are trying to document as many as are available in Nigeria. And once we have been able to document as many as we can, and as we know, that assignment has been given to some members of the subcommittee, which right now I think we have about 58 of those community organizations. I mean, existing community organizations, not new ones, that are structures that are already existing, and advocates. So we want to bring them to partner with us in developing some of our IC materials for education and awareness. And also some of those advocates, we also want to engage them in talking about screening uptakes for the different types of cancers in the different communities. So they don't have to work directly with the healthcare system. We want them to come from the community. Actually, we prefer that they are from the community, because if they are from the community listens to them. So, for example, working with some of the traditional leaders, the faith-based organizations, leaders, pastors, imams, the community, those communities listen to them. And so we will rather prefer to work with them because they have a larger audience. They are able to get the message across to their members, and their members listen to them. They respect them. Also, if you talk about the advocates, for example, some of those cancer survivors, champions, can also serve as advocates in our subcommittees. We already have some of them in our subcommittee working with us and helping us with tailoring our IC materials into appropriate languages that can be used in creating awareness and talking about cancer freely among members of the community. So they understand what to say, they'll know how to say it, they know how to reach the people. So they don't have to work directly with the community. All we are trying to do, once we have the list, we reach out to them and then we partner with them, and they help us to enter into the community and pass the message that we have across to the community members.
Thank you so much, Professor Oladoyinbo. I mean, I think one of the things that I'm really proud of about our technical working group, the Cancer Survivor Champions, and within each subcommittee, they are within each integration hub, they are within each geopolitical zone. And for me, is when they're sitting down there and looking you in your face, the sense of urgency comes. The sense of they don't even have to say anything. They are right there watching. They are our watchdogs. I'd say they are really truly our watchdogs. So next question. With the growing role of AI and digital health, how do you envision technology helping to improve cancer care in underserved communities while ensuring patient data remains secure and accessible? Outstanding question. We know who we go to. Don't wait for you. Don't wait to be called.
Yeah. Yeah, I think that's a very valuable question, and it's valuable when we're talking underserved communities. The illusion around the classification of underserved may be urban and rural, not quite so. When we did a remote analysis in Nigeria, we realized that outside of maybe three core states in Nigeria, much of Nigeria is underserved when it comes to cancer care, because a lot of the resources for cancer care are predominantly in Lagos, Abuja, and maybe in Enugu and maybe a few more states. But beyond that, much of Nigeria is underserved in that sense. So, and I think that's important when we're classifying this. It's not rural, urban, and so AI is significant in helping to bridge that gap. Like I said, within a cancer continuum, the first thing we want to deal with is early diagnosis. If we can diagnose early, it means that intervention can happen faster. It means that the potential for survivorship goes up significantly. That's one way in which that can happen. And who's the gatekeeper here? It's a primary care physician, because the primary care physician who determines whether a risk is elevated enough to require further examination or not. And so how do we empower the primary care physician to be able to identify risk of cancer even when it's not apparent, when the symptoms, because you have asymptomatic cancer incidents that occur, and then you've got the symptomatic one, but the reality is we've got to be able to catch it way earlier than we currently do. That's how we catch it at the primary care level. That's one way in which that can happen. When it comes to data governance, there are ways in which that can happen through federated learning systems. Nigeria has what you call NDPR, which I think is an adaptation of the GDPR, which is available in Europe, which is about basically norms that governs how a patient data is used and assessed. So yes, there are guardrails that can be put in place to ensure that we benefit from the technology that exists today, without necessarily exposing the patient in a way that is not acceptable in terms of data protection.
Yeah. Thank you so much, Mr. Baramosi. We are almost at 4 o'clock. If you just kind of give us about 5 more minutes, because we have our last questions that is coming up. Before our last question actually comes up, I want to give Dr. Bolajoko a chance to actually describe what are the benefits of early stage investigators being part of the program delivery units. We know that you are helping us a lot. You are helping with the almost day-to-day work. You are the one we call on when the reports are due. Thank God they're no longer monthly reports. They are now quarterly report. But, but can you tell us a little bit about what are the benefits for these early stage investigators being involved in the technical working group? And as you are telling it, I'm going to actually highlight, there are some members of our technical working groups that I'm going to highlight their comments. as Dr. Bolajoko talks, and then as we wrap up with the last question for the day.
Thank you so much, Dr. Dendino. I think there's an adage that I learned that if you want something to be sustainable, you have to bring younger persons to see what the older persons are doing. Because in the
Okay, what
next
do you mean? Stop. There's no age discrimination here.
no, I'm saying what the professors and the outstanding clinicians are doing now, in the next 10 years, we need younger persons. They would not be that young by then. They'll be able to learn. So for me, as an early stage investigator, and the opportunity we have as early stage investigator is to learn. The good thing is that we have early stage investigators in each of the subcommittee and we all had opportunity to be working with outstanding clinicians and investigators to see how things are being done. Like I know when I was talking with Mr. Bademusi, we talked a lot about this. This for me, it's a great learning experience. So that is the part I cherish the most. I know in the next 10 years, it's going to be another set of people who will be chairing this kind of committee and will be able to continuously, what we are building today, what this team, the current TWG is building today, we would have ready resource persons now that Dr. Amaka is working with, building the workforce. This is one credible way of building workforce. And I know that in years to come, we're going to have outstanding investigators, outstanding clinicians who had opportunity to have hands-on learning experience, who will be able to continue to advance cancer control for Africa, for Nigeria, and for the world. So that's my take on that.
Thank you so much, Dr. Bolajoko. We're going to go around, and as you can see, I'm highlighting some of our chairs that are on here complaining about us. Prof. Emeritus Professor okay, we hear you complaining. But the last question that I'm just going to take around is, what is one thing you want Nigerians to remember about this NCCP Technical Working Group? One sentence, short sentence. So I'm going to start with you, Dr. Lashibigon.
Well, one sentence, I'll keep it short. I think it's clear that we're on a new path, a new course. I mean, if all of this work from all the different subcommittees that have presented here has happened in the past just 60 days, I mean, the life course of a National Cancer Control Program is 5 years. You can be rest assured that the narrative will change. Cancer care would definitely have improved. The outcomes would have improved by 2030. So my word to Nigerians listening is trust the system. We can't do it alone. We need you all. We understand that perhaps maybe before there might have been some kind of reluctance, but we need everybody on board. Trust the system. We're definitely on a strong footing going forward.
Thank you so much, Dr. Lashibigon. Very well said. Professor Oladoyinbo, going on to you next.
Yeah, thank you, Prof. So one thing I would really want Nigerians, what will, by the end of this, to remember the TWG for is that the TWG is really working hard to ensure that we are not just looking at treatment alone. There is a lot of collaborative effort going on. That's why we have the different subcommittees, and because of these collaborations going on, I see us addressing the problems and all the challenges we've had with cancer in the past. I see it coming to a gradual end in Nigeria. As we continue to implement and put in all the efforts. And like Dr. Maka said, we need everybody on board. everybody is needed to contribute to this and to see that um, our goal and our objective of the TWG is achieved by the end of the day.
Okay, thank you so much, Dr. Bolajoko.
I think for
Give
me,
that
it's so
energy. Give
exciting
the
to
ESI
know.
energy.
Yeah, it's exciting to know that this is not just about writing report or submitting policy paper. This is action. So I know that cancer control in Nigeria has started. It's active and it's ongoing and will continue. I'm very excited about the NCCP.
Okay, Mr. Chris.
Yes, I would say that we would like to be remembered for the role that Nigerians played in improving and transforming cancer care in Nigeria. And it's a commitment and hard work that speaks excellence that was able to get us to that place. So for me, it's that we inspire people to see that Nigeria can be changed. Things can transform when people come together and they believe in one purpose, that they can actually transform things. Because people want to see hope. People want to be inspired. And when you're in a country where it looks like some things are not working, and then you have people who come together and make up their mind and say, give us 4 years, we're going to transform cancer care in this country. And they were able to achieve that. That's inspirational. Someone can take that and impact it into some other sector in the country. And so that's one of the things that it would be nice for us to be remembered for as a technical working group.
Thank you so much. That was very well said. Mr. Pramosi, last and not the least.
Yeah,
What do you want the TWG to be remembered for?
I think the TWG will be remembered for drastically changing the intervention of cancer care, the intervention of technology in cancer care, not just for Nigeria, but will set the tone for sub-Saharan Africa. While it's a Nigerian problem we're addressing, but it's clear that it's not unique to us. And I think that will be clearly evident with what we have planned, with the level of dedication and focus going on. Yeah, I'm quite confident that's what we'll be.
Yeah, thank you so much. For me, I want the TWG to remember that we put the patient in the center of it all. Nothing else matters. It's about the patient. It's about the survivors. It's about the families that are affected by cancer. It's about the communities that are affected by cancer. And we never forgot that. I think, we want to do the best that we want to do, and we pray that God will always be with us to achieve what we want to achieve. But as long as we really make it not about ourselves, not about our ego, not about our expertise, not about not being selfish, but it is really about this patient. It is really about the survivors. It is really about the communities. It's really about Nigerians. I think we would have done our work, and God will bless all the hard work that we do. And this is why it's so important for us to be transparent. This is why it's so important to consistently come every week. And regardless of what is going on, somebody's going to be here talking about the work of the TWG, talking about some of the activities, talking about what we want to do. So thank you so much to everyone that joined us today. Thank you so much to the technical working group and all your hard work. Thank you so much for jumping in and doing the hard work that is needed to be done. My co-moderator was unable to make it because he is still currently working in Enugu and wasn't able to join us. So thank you, Dr. Uche, for all what you do. And thank you to the leadership of the Federal Ministry of Health. To be honest with you, I have been working in Nigeria since 2006, the first time that I came back. And it is not about your good intention. It is about your good intention being received by the people who make, who really make everything work. If the Honorable Minister of State and the permanent secretary has not accepted what we offer, this would not happen. Okay, we will just continue to do everything in our silos, and there's not going to be this synergy of the work that we do. So thank you so much. Next week, Thursday live, we are bringing the geopolitical zone leaders to come and talk about what they are doing in all the geopolitical zones of Nigeria, as well as the FCT. That is going to be an important dialogue. So please join us then, and make sure you bring those tough questions for them. Until then, on behalf of the NCCP Technical Working Group, thank you and God bless our motherland, Nigeria, and God bless you too. Thank you.
Bye.
Thank you.
Bye, everyone.
Bye, everyone.
Bye, everyone.